So I'm very pleased to welcome Dr. Robert Turcotte. He's a member of our Department of Orthopedic Surgery. And Dr. Turcotte is one of our 8 members of the first cohort elected by his colleagues and the faculty to the Academy of Exemplary Physicians. So welcome, Dr. Turcotte. And
thank you. It's an honor.
Thank you for joining us. Maybe we could start by allowing you to describe what led you to orthopedic surgery. How did this idea develop, the passion that you have, and how did it come about?
Well, it's funny. I was good at school, let's say this, and when I got at the end of high school, my father was a fireman. My uncle is a fireman, so even though I applied for health science in college in Cégep, I applied to Montreal City to be a fireman, and they were not recruiting at the time. So that was in the mid-'70s. So I kept going on and then entered medicine. And my thoughts then were to be maybe an obstetrician or maybe an anesthetist, but never thought about surgery. And as a clerk, when I did my rotation in general surgery, I said, never I'll be a surgeon.
Really?
But I did a rotation in orthopedics. Then it was a Maisonneuve-Rosemont. And the team there, the people, the resident who were there kind of, really teased me in terms of, and I got excited about this area of surgery and medicine, which is a bit more mechanical, more practical. And that's how I got interested, and I still have been since then,
Wow, that's interesting. So you never intended to be in medicine and never thought about?
I thought about medicine in high school, but I wasn't sure. So what happened in life, sometimes there's circumstances. So that led me, and I was accepted a few weeks prior being accepted in medicine at the University of Montreal. I got accepted in vet school, which is harder to get in.
Yes.
And went to Saint-Hyacinthe, got my apartment and everything, and when got my acceptance in medicine, it was a tough decision, but I decided to go to medicine.
That's another interesting chapter.
Like I said, I entered medicine not thinking about being a surgeon. So that's one of the nice or fun thing about your cursus is that, you will evolve. You'll be exposed to different aspects of the medical world, and you might find areas of most interest to you.
Yes. So even within orthopedics, you chose certain pathways that are not as common as sort of just trauma surgery or hip replacements. You chose niches within orthopedics that were interesting.
Yeah. So that's a kind of a coincidence. It was a matter of being right at the right place at the right time. So in the late 70s, I trained in orthopedic in the mid-'80s. So at that time, orthopedic oncology, which was taking care of bone and soft tissue tumor, got a bit more popular with big centers such as Boston, New York, and Mayo Clinic. And they were, instead of usually we used to amputate patients with cancer in their limb. People were starting now to do limb salvage and do prosthetic replacement was starting. A lot of allografts were popular at that time, take a cadaver bone to replace someone else's bone. And this was a new area, very exciting. And there were no one in Montreal, basically, at that point. So every orthopedic surgeon was doing his cancer care, but without, let's say, proper training or knowledge or connections. So I got interested into this, and that's how I selected, after training in orthopedics, I selected this area to do a couple of fellowship into. And came back to Montreal and built a practice. Now, I was not the first to do orthopedic oncology, but I would say I was the one who became better known, attracted more referral, and kind of centralize the management of bone and soft tissue sarcoma, as opposed to previously every hospital was doing their own.
So you focused a lot of your work on that domain.
Yes.
And looked after those patients.
Yep.
And you told me earlier that now you were a pioneer in another area, right, which is another way to deal with and help patients who had amputations.
Yeah.
And can you tell us a little bit about that?
Well, yeah. So, as an orthopedic oncologist in the 80s, 90s, and early 2000, we were exposed to many new technologies, new technique, new devices
Right.
to provide better function to our patient or better treatment. And unfortunately, we still have to amputate some of our cancer patients.
Right.
And I was always keen to try to do the best stump for the patient in order for him to get fitted with a prosthesis in a better way. So this was always the training I did to my fellows and residents, was really to teach them you need a nice stump if you want the patient to use it.
Sure.
Otherwise, if they have a bad stump, they won't do functionally very well with their socket prosthesis. And so I had always a bit of connection with the doctors who oversees amputees, which are the physiatrists, the rehab doctors, especially at the Montreal Rehab Institute,
Right.
which is now the Lindsay Gingras Rehab Institute. And it came to our attention in the early 2000s that there was a group in Sweden doing what they call Osseointegration, which is essentially the same principle, having an implanted tooth.
Right.
And basically it's to getting a rod into your bone, to your femur, namely, across the skin. So this become a transcutaneous implant, like a tooth implant.
Right.
And where you would connect your prosthesis on and avoid all the difficulties relating to a socket.
Right.
And we visited for a week in Sweden in 2002 and were convinced about the benefit, despite some risk, but the benefit for the patient who had this procedure, and tried to implement it when we returned. So it took like a year of discussion, and
Sure.
finally we failed for many reasons. People thought we were crazy. In orthopedics, having an implant through your bone, through your skin, makes nonsense. This is 100% sure you'll get an infection. So people were not very much there to support us. Plus, it was overly expensive. Back then, the implant was $60,000.
Wow.
And so the hospital had no incentive, to embark on this journey. So basically, the project went dead. And in 2016, there was a renewed interest, especially at the Rehab Institute, because there have been a couple of surgeons. The Swedish surgeon still kept, publishing and augmenting their experience. And there were trainees both in Netherlands and in Australia who also started to use a different implant and have done many cases and showing exciting results, so to speak.
Wow.
So in 2017, we went to Australia for a week with the rehab team. And when we came back, we initiated in December 2017 the first Osseointegration clinic in the country, and started to see patient and book patient for surgery. At that time, the procedure was not accepted by the RAMQ
Right.
or the hospital, but we had the option for private care. So we started to do the first few ones in private.
Mm.
And after that, with the discussion with the ministry, they came up with a project where they would support the cost of the implant and monitoring basically with Ines the benefit of this procedure.
Right.
And that's how we started in Canada for the first program and until the support was withdrawn last summer. But this is this was for kind of the research aspect of it.
Right.
But the procedure is still available through the RAMQ.
But the research showed that there's a benefit for patients.
There's definitely a benefit. There's no question quality of life and function is improved.
Yes.
We had patients who were wheelchair-bounded that are walking without any aids.
Wow.
Especially the bilateral femur amputee. We have patient, let's say you have a brachial plexus palsy and an amputation in your leg, or you have an amputation of your upper arm and lower limb. These patients putting a socket prosthesis with one hand, changing the socking during the day because the stump gets more swollen or less, or you sweat a lot. So this was a big issue for them, sometimes taking half an hour to put the prosthesis on. Now it takes 10 seconds to click the prosthesis on the,
Right.
and it's done with one end. So these patients were really, very convincing evidence
Sure.
that the procedure is worth it. Now, it's a costly implant. Second, there's definitive risk for infection,
Right.
especially chronic osteomyelitis. But that risk, which is about 20% at 10 years, is acceptable, and most patients with chronic osteo live on with their implant, their benefit with chronic oral suppression antibiotics,
Right.
So yes, so we're still early on. We started the first case in 2018, so the oldest one is 8 years out,
Right.
doing very well. And we've been doing cases over the years. Yeah. We're about over 60 now.
So is that a common kind of story where those who are pioneers are told by their colleagues it won't work, it can't work, it makes no sense?
Yeah. We're not in public healthcare system. We're not in an environment where innovation is well supported, because especially now with evidence-based medicine, you would like everything you do, every money you spend is for the right purpose and proven benefit. Certainly, if you try a new drug or you try a new device, this is not the case. Of course, these come after reflection, after whether animal studies and things like that. But when you want to make the next move, it's becoming very, very difficult.
Right.
And so we were not pioneering this technique worldwide, but we certainly were aware and could have started 20 years ago.
Wow.
Without the possible benefit we could have got from this, including, developing research,
Sure.
Because when you start something, it's not the final version.
Right.
So when they started hip replacement in the late 60s in Montreal, this was something new. There were issues. The implants were not the best. We learned over the years.
Yes.
And now it's a very standard procedure that lasts for 20, 30 years without difficulty, changing the life of the patient.
Yes.
And so this is a bit similar to this. And this is especially foreseen quite exciting to put a robotic implant or putting especially for upper extremity, whether it's brain managed hand or whether it's neural impulsion. And you need something stable. A socket won't do the job. So there's people already that have done these kind of robotic implantation. But that's the way of the future. This is the step prior to limb regeneration.
Okay.
So you're combining biology, osseointegration, so bone attaching a piece of metal, and the electronic.
Right. And computers.
And computer, yeah.
Right. And these are the links to the brain, right? There's neural.
Yeah.
Neural.
So now they're working with some sensor. Just with your thought, you can activate your hand.
Yes.
Or you may have electrodes under your skin that, or into your muscle.
Right.
That will activate the finger, and you can have retro feedback. So if you squeeze an egg, you'll kind of have a retroaction. You'll feel not to squeeze it too much, so you can control. It's amazing. Even the amputees, they're telling us when they walk on the ground, whether it's concrete, carpet, gravel, they feel the difference.
Really?
They walk on a wire and they feel, oh, I'm on a wire. And this is similar to if you hit your tooth, or masticating something, you'll have the feeling if the food is hard or soft. Right. So this is the same. They don't have the damping effect of a socket and your soft tissue envelope and your stocking. This is right into the bone, so they feel it.
So they get the feedback.
They get a feedback, so there's less fall.
Right.
They can react faster, like if they slip and things like that. So there's some benefit.
Right.
We call this osteoperception.
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 That's interesting. That's interesting. So it sounds like your practice has always included the entire span of life, pediatrics to geriatrics, right? You've always done that.
Well, in orthopedic oncology, it covers kids to elderly.
Right.
For the amputees, usually for the adult, you need a mature skeleton to implant this. But so my career, I always did kids and adult. And in kids, bone sarcoma especially, is about 10% of all cancer. So it's a common cancer in kids. It's not a really common cancer in mankind. It's about 1% of bone sarcoma is about 1% of all cancer.
Right.
But in kids, about 10% of all cancer. Yeah.
So it's a big volume.
It's not a big volume, but it's a prevalent cancer in kids.
Right.
And in these, the challenge is really to deal with the limb reconstruction in a context that the bone is not fully grown.
Okay.
That's still growing to occur. If you do a technique in a 5-year-old, you're more limited in your choice than doing an adult.
Sure. Tell me, with this span of different activities, what is a day at work for you look like? How is it organized? Give us a sense of, you say, I get up early because I'm a surgeon, I'm going to work. What then happens all day?
Well, I mean, I'm not sure I'm a role model as per today's highs, but my work has been essentially the main focus of my life. Not that I was only doing this and having no family to take care of, things like that, but most of my time was devoted to medicine,
right?
Especially. Attending meetings, for instance, so not taking that much vacation. I would take vacation, but, making sure I attend an important meeting, making sure I'm organized and work efficiently, making sure that I keep up, to the newer things, of continual medical education in my field. Plus, also, if you want to have an impact on, let's say, not only on your daily activity as a clinician, but on the daily activities within the system, I would say, you need to get involved somehow at the whether administrative level or political level and things like that. So I'm not a politician. I speak the truth and nothing else, so I couldn't be a very good politician. But I got involved with the Quebec Orthopaedic Association, which is a branch of the FMHS, the Specialized Doctor Union, so to speak.
Yes.
And so I work with people like Dr. Barrett, who was president of the FMHS, and others, pertaining to the affair of relating to orthopedics in this province.
Right.
So whether it's funding, whether it's the coding, whether it was the policies, healthcare policies, whether it was these, all the CRDS, which is the centralized management of consultation, and stuff like that. So I was involved, in fact, to make sure that not only in my setting, in my hospital, but also province-wide, some of our vision or some of our important aspect of our practice to make our life and the life of our patient easier were kind of addressed. So this is, you always get half satisfied of these actions because you have competing goals from the different stakeholders, including the government, the hospital, but nevertheless, I think that was important too.
To make that work for the community.
To network and to be to advocate,
Yes.
both for the patient and the surgeon, certainly.
In what way do you, in your day-to-day work, advocate for patients? How does that?
Well, my day, I've always been an early bird. Even when I was in medical school, I live in Montreal with my family, brothers, sisters, and everything. So studying at the end of the day, an evening was not easy. There was too much noise, TV running, and things like that. So usually I would go to bed early, and I would be up at 4 and do my studying at 4, from 4 to 7 before going to university and not doing on evening. So through my career, I've always been an early bird. I've been in the office, at the general at 5 every morning, and working the morning and not working in the evening.
Right.
Whether it was for the kids, if you want to be there, if you want to
Right.
help and interact a bit with your kids. And after that, I was too tired. So work in the morning when things are quiet, nobody's
Yes.
around, and you do your stuff.
Peaceful.
And always, even as a resident, I was rounding at 6:30, making sure everything was done. So when you get to the clinic on the OR, you don't get these phone calls, or you don't
Right.
need to say, oh, I need to leave now. I need to sign a discharge, or I need
Sure.
to go reorder this. So I think it's a way of seeing what you need to do, getting organized to make it the most efficient, and try to avoid, all the difficulty or unexpected issues that may happen during the day.
Right. Right.
So what you can control, you try to make the effort of
Right.
doing the right thing. But after that, it was just, being there for your patient, running the busy clinic in orthopedics,
Right.
rounding on patient, which I think is important. And that becomes more and more difficult now that we're split over many
sites.
centers and,
Yeah.
the outpatient surgery and private clinics and this and that. So this is an issue. And even for the resident now, because they're
Yes.
splitted. They have to
Okay.
be there if you do surgery at 8 and at La Salle Hospital,
Wow.
you need them to be at 6 or 6:30 in the hospital to round. So it's
Right,
not always
right,
easy to achieve all the goals perfectly, but nevertheless, that's that's the price to pay,
Yes.
for trying to make things better.
Right.
But that was not pain for me. So
Yeah, that worked for you. But
I,
there must be, like for everybody in every field, some days are really good days and some days are not. What for you is a good day? When you get home, you say, today was a really good day.
well, a good day is when you I would say overachieve, or things went better than expected. So sometimes, we embark on big surgery that will last 8, 10, 15 hours. And it's nice when it goes smoothly. The patient comes out of surgery without, too much difficulties,
Right.
and that the outcome is good. Sometimes, you start your day bad. You start the case late. It takes time to put the patient under, much more than, sometimes if you start a big case at noon instead of at 9, let's say, then you end up with the evening shift of nurses, which are a bit less experienced about what you do.
Right.
You get tired because it's later during the day, and so this is not ideal. And this sometimes can, lead to more difficulties and things like that. And then you end up at the end of the day, you're less satisfied of your your interaction with others. But most of the time, these were rare events, I would say.
Good.
And also when patients do bad, especially when they do bad because you feel you have a responsibility into their difficulties, whether it's an infection or cancer comes back. When it's, you've done what you had to do, and life is life, and cancer may progress.
Sure.
But so you need to forgive yourself a bit. You need to recognize that you cannot control everything, including residents, fellows, nurses. You need to accept that people around you might not do exactly what you would have liked them to do. But that's part of life. But you need at the same time to be there for them, to assist, to teach them, to educate.
Right. It sounds like you spend a lot of attention, or pay a lot of attention, to teaching residents and fellows and students. Is that an important part of?
That was very important. I was newer in my field a bit when I started. So teaching resident and future colleagues, that maybe sarcoma should be managed in a centralized way, to recognize the tumor, make sure someone doesn't do the wrong gesture.
Right.
So things like that. These were important things. And also, this was an evolving subspecialty. And so there was interest, there was a lot of new things in that field. So to teach, sorry.
Right.
And, but I love having residents. I loved having fellows. I was not necessarily always smooth with them. I was demanding, so to speak. At the same time, if you don't have discipline as a resident or a student, you won't have it as a staff. So it's a matter of organizing your life, accepting some of the discomfort of a clinical practice, being there for your patient, which may require attention at any time of any days or any hours, and that's part of our job.
Yeah.
I mean, so you need to combine your family life, the need of your patient, and not to kind of. Some people tend to isolate. When I'm with my family, I don't want to hear anything about work, and when I'm at work. So you cannot do that. People may need you. Things happen, so you need to be available for everyone. Even your colleague, get a phone call, yesterday evening got a phone call from a colleague about a patient he's doing today, and he wanted to make sure that he was doing the right thing.
Wow.
So that's part of our job,
And you spend time on that, right?
Yeah. This is not painful. This is not demanding. This is my life, and I'm very honored that a former student would get back to me to ask for my opinion.
Wow.
I mean, this is very rewarding.
Yes. Rewarding to you as a teacher.
As a teacher.
To say, can you help me? Right. And what are the kinds of things that are in your mind that you keep on saying to yourself, there's a patient involved here, I must do something extra? What pushes you to do that? And what are the things you do to make sure that patients get the attention they need?
So let's say, we live in a public system which, especially at the moment, has many limitations. Maybe things were a bit easier in my early practice, but nevertheless, it's been a public system with all the difficulty getting tests, getting access to the OR, and so on. When I was at Mayo is kind of the Mecca. It's the paradise for a doctor, for a surgeon. There's no wait list. You have 15 cases to do surgery on today. You'll finish at 2 a.m, but they will let you go. You want an MRI, you'll have an MRI in the same day, and then the report will be written in the file. There was a system which was very, very outstanding, I would say. So when I came back from my Mayo experience, I tried somewhat to reproduce that model. Right. And because, I feel the patient, especially when you come with a cancer, I feel the patient is lost, is disorganized.
Yes.
And to have him navigate alone in the Dallas of the testing, the medical visit, the consultation, this and that, was very, very difficult. So I managed in every institution I worked to develop a system where X-rays, including CT scan, were done on a walk-in basis. You're in the clinic, you need a CT, you get it right away. Wow. And this is still old at the moment. So we're the only, shouldn't say it too loud, but we're the only service that gets walk-in CTs and X-rays. We cannot get an MRI, obviously, in the same day, but we also, partnered with the radiologist when you need an MRI or when we have slots for MRI dedicated for our patient. So making things easier that the patient, when he comes to the clinic, he knows where he's going. He knows what's coming, forward for him. He will need these tests. Especially, we have patients coming from all over the province. Right. So you don't want to drive back and forth or stay a week in Montreal because you need a CT scan of your chest. So we would organize things either in advance. When the patient comes, let's say those tests that really need to be planned, like a guided biopsy, for instance, or an MRI, we would see the patient the same day. So if you drive from Abitibi, okay, let's wait a few more days, then we won't see you tomorrow. We'll see you next week. But when you come, you'll have your MRI, you'll see us, you'll have your biopsy, and you go back, and then we'll know what we're dealing with and see what happens next. As opposed to come and visit, you need an MRI, so go back home and in 2 weeks. Right. manage for the patient, ideally, to leave the hospital, the outpatient clinic with all the appointments scheduled, so they know. Now, in addition, we have access to a PIVO nurse in cancer, so that one nurse can monitor and help the patient instead of us answering all the phone calls, all the queries. And we manage also, and this is utmost importance, to develop a team of collaboration among pathologists, radiologists, radiation therapists, medical oncologists, so that we work all together, speak the same language, and all oriented toward the same goal of making things the most efficient possible.
Right.
And we've been successful. It's been, it's a journey. They've been up and down, but we're the surgeon who speaks the most to the pathologist. We know about that, yeah. So we're the surgeon because we're depending on the pathologist.
Sure.
You're as good as your pathologist is in bone and soft tissue tumors. And so they're quick to provide with a diagnosis. Usually a day or two, we have a preliminary diagnosis. In the OR, we do frozen section. We have the sarcoma pathologist on site, not the general pathologist. So the team is built that people know that we work with the same people. If we do a lot of plastic procedure for reconstruction of tissue after surgery, so we tend to work with the same plastic surgeons.
Sure.
And, you develop a complicity. They know what you expect, and vice versa. And they would see the patient the same day. So pick up the phone and to the plastic surgeon, and he's nearby, or even in the OR, they say, okay, keep the patient. I'll come down between two cases. So this was a system we developed, and it was appreciated by patient, even though sometimes they don't realize it might be different in other services. But we were adamant from this. And this system, what happened is that people try establishing this, and people then trying to keep the pace. You create needs to ensure that the system will self-perpetuate itself. So you need a clerk, to organize all this. So you create the need for a clerk. Eventually, the clerk shows up. And we needed, we were among the first to get the PIVO nurse.
Yes.
So you get a PIVO nurse. You you need slots for biopsy on Monday, let's say. So finally radiology would agree to put slots for you on Monday for your patient. So this is the way we work.
Yes.
Everyone should accept similarly these services, but at the same time, if everyone sits and waits for someone to be called and or process direct with the facts, and God knows what happened.
Yeah.
So we never functioned like this. I always wanted, maybe I was too rigid. I was too not anxious about this, but if you need an MRI, you cannot just issue the MRI and fax it and hope someone will realize that this is urgent. The best thing is to pick up the phone and say, I need a date for the MRI.
Right.
This is the way we work, and I still work. And with the complicity of other, it worked pretty well.
It sounds like it took a lot of energy on your part to make it happen.
Yes.
So what was this? And the reason I say this, I've heard patients talk about one of their feelings, if they're sick or chronically ill, of being in the hospital is a feeling of chaos. And it sounds like you understood that, and you worked to make sure the patient didn't feel that there was chaos around him or her, right? That it was organized, that you understood what the patient was feeling, and you took care of things that sound small, like not having to travel twice. So how did you make that happen?
Just by organization and having, let's say, the interest or the will or the energy to try to implement this. And I must say, I've worked in different institutions, and it's been similar everywhere. You need someone to lead, to show the way, to push.
Right.
And at the same time, you want to be fine with the others. If you're asking the radiology secretary for a favor, you don't want to be harsh on her. You
Of course.
want to explain it, and then you develop. Then they know you.
Yes.
Oh, it's Dr. X. I know if I tell him no CT, he will call me back, and he will call the radiologist to push. So that people get organized to kind of support you. That needs energy and interest. Maybe sometime one of the weakness in our system is I wouldn't say the lack of interest, but people are not eager enough to, unless it's exceptional. You have something very urgent, you might pick up the phone. But let's say for the more routine cases, people will put it on the pile.
Sure.
It's same for surgery. So I never accepted that we delay consultation in our field. So every time there was tumor, it was immediate access to the clinic.
Right.
So the consult come today, the clinic is on Monday, the patient is booked for Monday. Not saying, the clinic is a bit busy, we'll put it in 2 weeks and then that. No, until you know what it is about, you have to treat it. Now we triage a bit more, obviously. But despite the triage, sometimes you're very limited. Sometimes the patient had no test, so you have no real clue beside a bump or pain for the cause of their problem. So you cannot have waiting lists to access a cancer clinic.
Right. Okay.
So, and sometimes we went after the hours, but that's the way it was.
Right.
And the people we work with oftentimes stayed longer, even sometimes not paid, because they felt part of a team. They felt that, everyone was buying into this.
Right.
And it worked well. And same for the OR time. I always thought, that our patients are often on chemotherapy protocol. There's a window of opportunity for surgery. And you cannot accept that, if it should be in 2 weeks, the surgery, that will be in 2 months. This is unacceptable. Now, we were fortunate to have low volume. It's not like other type of tumor, which are much more common and where wait lists are more easy to understand. But in our field, there was less patient. But I never took a no for an answer. You need to make your point. You need to find for flex time. You need to speak to your chairman saying, listen, this case cannot wait. So bump one of my colleague and, thing like that. You work for the best of the patient.
Right.
So, but it's it's a dedication, I guess. For me, it was natural, but it's not like this for everyone.
How do you transmit that to the next generation?
Well, I think, I got echoes or I got feedback that for some I was a role model for my dedication and time and passion. The goal, it was the same as I was a fellow in the state that you see something, you try to reproduce it. It's like learning about surgical techniques. You might go to friends and you learn about a technique, and for the same problem, you go in the state and they do something different, and then you'll pick up what you feel is the best for the patient. It's the same for your daily activities. What you've learned, the model you've seen, try to implement that. And if you cannot implement, try to adjust or improve what can be improved. But this is, and I was lucky when I came I worked 15 years at Maisonneuve before I moved to MUHC. And when I came to MUHC, the system I implemented at Maisonneuve was not there. So this was a work in progress. It took, a few years, but we were, back to most of the efficiency that I had developed there, and I started from scratch. So it's possible. But you need to push. You need to get people on your side.
So what's interesting is that you can learn from other centers not only about a surgical technique or a new combination chemo, you can also learn how to organize the clinic, right?
Absolutely.
And how to make sure that patients don't come in with an appointment at 7:30 in the morning and they wait till noon to be seen.
This may happen, but it's not because I'm showing late.
Right.
That's our responsibility. Unless you're in surgery, something happened, emergency. But, first you need to be on time, even if not earlier, first thing. And second, people need to understand we had no wait in our clinic, no wait in terms of waiting to access the clinic.
Right.
But, if I overbook my clinic
Sure.
to see you today instead of next week, you need to understand you may wait longer than
Sure.
what you would expect. And I think most of the time people were, kind of recognizing the fact there's a price to pay to be seen fast.
Right.
But no, and I think most is very doable. So our students or residents, when they went into their personal, practice,
Yes.
they probably are taking part of what I've shown,
Sure.
what maybe the trauma clinic have shown, and try to make their own environment the most efficient and workable.
It sounds like you need an interesting combination. You need to be a little dirigiste, a little. Mm-hmm. You need to be clear.
For sure.
Right. You need to be clear about what you expect, but you also need to respect the person you're dealing with.
Absolutely.
Because if you just yell at them, it's not going to happen, or it'll only happen once. Right. So it's really an interpersonal issue, which is true in dealing with patients, right?
Yep. With
colleagues, with trainees, and with the clerk that you're talking about.
Yeah.
It's the same kind of...
You need, well, I was not necessarily consider myself as a leader, but you need to lead the way. You need to sometimes, let's say, I would say convince, but I don't want to use force into.
Sure.
Sorry. But you need to convince your colleague of the good reason to, let's say, act a bit differently. So we initiated, a sarcoma tumor board, like many disease sites have. And we're surgeons, so we have busy days. So for us, doing a tumor board at noon is something that's not possible.
Right.
So we elected to have tumor board at 7:30. Initially, I proposed 7.
Right.
But having medical oncologists and radiologists, even at 7:30, we're the only one. And so it was not felt possible. But, since the surgeon were there, the other people were buying in, then the radiologist was kind of the only one who was reluctant. They say, okay, we'll be there, Right. And now it's been functioning very well, and everyone is there. It's a very well-attended tumor board. And so that's the way. You need to push a little bit.
Yes.
Try to convince people. And oftentimes, if it makes sense, people will embark,
Yes, yeah. So you told me that you're now kind of semi-retiring slowly. So you'll be doing what, less surgery or less clinical work? Or how will you organize from a very, very busy decades of work?
Mm-hmm.
How will you organize a transition that still gives you the engagement, the comfort of being part of it?
I was a busy surgeon. But, I had a busy practice and schedule, but I'm also lazy. So I like to rest. I like to read.
Right.
I go hunting. We have now I go hunting with my son, but I had my cousin, so we have a hunting party every year.
Right.
And so you need to do other things than just work. Some do not need to, but I needed to.
Right.
And I didn't see myself being very busy, and most of what I am has been relating to my work.
Sure.
As a doctor, this is what we are.
Yes.
We're first doctors besides anything, oftentimes, and I couldn't see myself abruptly dropping everything. I'm going to retirement, and I'll go play golf, a few times a week. That was not for me. And I was fortunate to have this new program that the RAMQ and the FMHQ have negotiated that allowed you to kind of transition, wean out progressively, allowing you to still be working to a certain extent and having your position freed to recruit someone. So this is how this. If this program would have been there, maybe I would have waited a year or
Right.
two. But at the same time, I felt that getting older, you do complex cases, you have difficult complication,
Sure.
you need to be available, and I was getting a bit more tired
Sure.
of this. So having fresh blood, young guy coming and lifting up,
Yes.
the education, the research level for me was the way to do. So we recruited someone to replace me who has. I was a clinician. I did some clinical research,
Right.
but I was always very supportive of basic science research. But I'm not a scientist myself. And over the year, we recruited 2 full-time PhD in doing
Wow.
research in sarcoma that we managed to found. And I always dreamed of recruiting a clinician scientist.
Right.
So the person who replaces me will be a clinician scientist.
Right.
And so what I wanted is to kind of show the way, not disappear, but
Right.
stay around a year or two to show the youngsters how to do things, to kind of be a role model, be
Yes.
some kind of not role model in that aspect of telling them what to do, but just
Yeah.
showing the way things should be done, because people are not necessarily trained from McGill or
Sure.
trained with me when we recruit them, and to mentor them. Yeah, that's the
Of
right
course.
term, to mentor them.
Of course.
And at the same time, I was still the head of the sarcoma program. I will step down in July,
Right.
but keeping running the things I've done, leaving the time for the others to understand,
Right.
to network, to pick up,
Right.
and to understand the intrication, if you wish, of
Sure.
everything, whether it's the research funds, whether it's the
Yes.
the patient, the functioning of the clinic, and everything. And at the same time, I wanted to do research.
Yep.
And so right now I'm involved in some basic research in augmented reality and
Okay.
robotic surgery. So we're working on level 4 robotics, having robots performing surgery
Wow.
and not holding your hand to perform surgery, but really you plan the surgery and the robot execute the procedure, especially bone cuts,
Sure.
So, and we're working on this. And teaching. So
Sure.
basically, I work 2.5 days a week. I don't do surgery anymore for cancer. I
Right.
don't see new patient for cancer. I just right now do follow-up of my
Right.
former patients. And I still do the Osseointegration because the
Sure.
newcomers to replace me is coming next year. So until then, I will keep doing the clinic and
Right.
the procedure for Osseointegration. But this is less demanding, and complications are much lesser in
Sure.
experience. So
Sure.
doing this and a bit of research, at the same time having a bit more free time for grandchildren and
Of course.
family.
Other hobbies. Yeah.
I'll be there, yeah. So I have a woodland. I have with the sugar shack, and so
Oh, wow.
maybe, doing maple
Beautiful.
syrup. We got equipped with a dog and a cat.
You're ready.
I have a boat. So we're kind of busy. I can manage myself physically and emotionally
Good.
well, and fading out progressively.
Right. Right. First of all, thank you for your honesty, your candor, and some really beautiful descriptions. Is there something I haven't asked you that you would like to share with us?
Well, I think as a doctor, I know I'm from a different generation. We used to put work as a doctor some kind of permanent over family life, over leisure time, and things
Sure.
like that. So sure, I want that advocates balance in your life. At the same time, one needs to understand that in medicine, you're the focus of many of your patients awaiting
Right.
you to help them, to provide answers, and so on. So the least you work, depending where you work, because we're all not the same. Cancer care
Sure.
is not the same as doing toe surgery,
Right.
So, but being away a large part of the time where your patient cannot be reached, and you cannot always count on your colleagues to
Sure.
make decision. They don't know about these patients, or
Yes.
they're not expert in your field. So yeah, they can wash out the wound, but they cannot exchange an implant or
Sure.
thing like that. So you need to put the time. And to me, it's always been a reason that as doctor we were well paid and well recognized by society.
Sure.
Not because we go to school a long time. There's many people that go to school much more than us,
Sure.
and they usually don't make same earning as us. But part of the reason you get well paid is because of this. You work on weekends, you get called at
Yeah.
night. You might not be the family at Christmas because there's a need.
Right.
And I think one needs to understand that if you go to medicine, it's not to work, from 9 to 2, 4 days a week. And it should be your goal.
Right.
It might be easier to do in a different field than surgery, for instance.
Sure.
But certainly that was not my vision of doctor. Right. And I think we don't help ourselves by kind of switching the work hours and the vision, because then the justification of our status becomes less and less obvious.
Right. Right.
So this is the best way to get to salary basis. And I understand all the changes that occur in medicine,
Sure.
whether it's, women coming in large number, the younger wanted to
Sure.
do other things. But at the same time, if you prefer to be on the golf course than to be in the OR, there's a problem as a surgeon.
Right.
Now, sometimes we're pushed out of the OR because
Right.
we would like to do more and we're restricted. But at the same time, yeah, to me, it was kind of the patient first,
Yes.
even though it's not always possible or desirable. But I wouldn't see myself working 3 days a week and or 6 months a year. That's why I stopped doing cancer surgery.
Right.
I didn't miss that, but I never took more than 2 weeks of vacation
Right.
in a row.
Huh.
One, I was often only in my field.
Yes.
So if you're gone, there's no one to answer. So it's difficult to go for a month. And like if you have a cancer, to wait a month for the doctor
Sure.
to come back. So that was one issue. The other issue is that what happened. You do big surgery, you have complication.
Yes.
So to drop to others your problem, I didn't want to do that. That's
Right.
one of the reasons. As semi-retirement, I stopped doing surgery. Not only I didn't want to bother by the complication, if you wish,
Sure.
but I didn't want my colleagues to pick up
Right.
because I was working part-time.
Right. Right.
So I'm more in for, you're in or out. And I think if I'm not available, better stop
Right.
doing
To
this.
be clear.
Yeah.
Good.
So I encourage the new generation to embrace their career, whatever field they
Right.
take in medicine, and to have a reflection about how they want to interact with their patient, what's their role, how they see themselves, and pick up, I guess, an area of medicine that will suit all their aspiration.
Right. Right.
Whether you want to be more involved in one field or more at home and things like that.
Sure.
It's funny when we entered medicine, I remember the first year we had not the initiation, but we have kind of a socialization
Yes.
meetings. And I remember that some of my colleagues in first year medical school had registered to medicine to become diplomat, to become administrators.
Uh-huh.
They were in medicine to do other things than
Right.
curing patient,
Sure.
so to speak. At the same time, it showed that medicine is a very wide
Yes.
area. Not only there's about 40 subspecialties,
Right.
including family medicine, but you can, we need doctors who are administrators that
Yeah.
knows what the doctor is and what doctors do, so
Right.
to support
Right.
us better. We need people who are teachers.
Yep.
We need people who are dean, and things like that. So medicine is very vast. There is for many tastes in medicine, but you need to pick for your own taste and
Sure.
make sure what you do is pleasant to you and to the
Right.
people you serve.
Appropriate. That's
That's
great.
my advice.
Thank you for sharing that.
Thanks for the invitation.
Congratulations on being honored as a member of the Academy. And thank you so much for being with us today and taking the time and sharing what you've learned from decades of experience. That was very kind of you. Thank you.
Thank you. Thank you, Abe.